the webinar.
ওয়ালাইকুম সালাম। হ্যাঁ, আপনি কি খবর দিচ্ছেন ভাই?
একটু basics to update. This is the continuation of the previous one, and this will be delivered by Professor Ghulam Mustafa. I invite Professor Mohammad Ghulam Mustafa to present his lecture. Thank you very much. Professor Mustafa. Professor Mustafa, are you ready? Yes.
ইয়ে করা যাচ্ছে কি, দেখা যাচ্ছে?
হ্যাঁ, দেখা যাচ্ছে।
আমার স্ক্রিন দেখা যাচ্ছে?
হ্যাঁ, ক্লিয়ার।
দেখা Mr. Chairman of this session, distinguished participants, my junior and senior colleagues, good evening. Today is the Christmas Day. I offer you all Happy Christmas Day from my side. Today we are going to present Prostate Pathology Part 2. In my last presentation, I covered histology of prostate, then diagnostic criteria of prostatic cancer and other benign entities, and a detailed evolution of Gleason score. So today we'll start prostatic adenocarcinoma variants. So there are some variants or some adenocarcinoma, they mimic benign condition also. Now this is a table in 2016 WHO classification of histological variants of acinar adenocarcinoma of prostate. These are variants, it was listed in this classification, and later on some other variants has come out. The first variant is atrophic adenocarcinoma. Atrophic pattern adenocarcinoma may be seen in a sporadic setting or following radiation or androgen deprivation therapy, and is characterized by cytoplasmic volume loss, just like benign atrophy. An infiltrative arrangement of glands displaying cytoplasmic volume loss, macronucleoli and nucleomegaly, along with admixed non-atrophic usual acinar adenocarcinoma with a moderate amount of cytoplasm is typical. This is the atrophic variant of acinar adenocarcinoma. Here, this is the normal benign atrophy, and on this side, you see there are infiltrative small glands. These are infiltrative, and the size of the cytoplasm is very minimum. These are actually the cells show atrophic changes. On the right hand side, this is the normal acinar adenocarcinoma. It may present, and usually it is present with normal acinar adenocarcinoma. The next variant is pseudo-hyperplastic adenocarcinoma. Pseudo-hyperplastic adenocarcinoma can simulate the appearance of usual epithelial hyperplasia. And this variant accounts for a large percentage of needle biopsy cases misdiagnosed as benign. We miss it. The incidence in adenocarcinoma needle core cases is 2%. And in prostatic transurethral resection, it is 3%. And in whole gland, it is 11%. And this variant displays papillary infoldings, luminal undulations, branching and cystic dilatation. An infiltrative pattern can be detected in a minority of cases. So it looks like normal. It looks like benign hyperplasia. And sometimes it presents papillary structure formation, and it is very difficult in needle biopsy to to identify this entity, but still it can be diagnosed. The next variant is microcystic adenocarcinoma. Microcystic adenocarcinoma exhibits gland dilatation with intermediate sized glands that are on average 10 times the size of usual small acinar adenocarcinoma glands. And these pattern is usually present along with, or these are admixed with the usual acinar adenocarcinoma. The next variant is foamy gland adenocarcinoma. Foamy gland adenocarcinoma can be deceptively benign appearing due to lack of nuclear atypia. Clinically, the mean age at diagnosis is 65 years. And like many men with pseudo-benign carcinomas, these men present with an elevated serum prostate-specific antigen level. Microscopically, foamy gland adenocarcinoma is characterized by abundant foamy or xanthomatous type cytoplasm with pycnotic nuclei being frequent. Intraluminal dense pink secretions are often identified. Foamy glands are observed admixed with usual acinar adenocarcinoma in 17% of needle biopsy cases and 13 to 23% of radical prostatectomy cases. So this is the foamy gland adenocarcinoma. These are actually not foam cells. These are carcinoma cells. And if you do a CD68, this will be negative. Now this is a chart, this is a table which shows the subtypes, morphological patterns, immunohistochemical characteristics, Gleason score, and response to androgen deprivation therapy. So atrophic variant, here their scoring is done as usual, Gleason score, and they are androgen responder, pseudo-hyperplastic. Here are the characteristics as we just told. And the pseudo-hyperplastic variants are usually 3+3. They are also responder. Foamy gland, here also their Gleason score is based on the architecture. They are also androgen responder. Mucinous carcinoma, when more than 25% of the total tumor shows extracellular mucin. And intraluminal mucinous material does not qualify, and extraprostatic origin must be excluded. So extra prostatic origin must be excluded before diagnosing mucinous adenocarcinoma. And here usually it is 4+4, and they are also responder. Signating variant, here more than 25% of the tumor volume shows signating cells. These cells contain optically clear vacuoles displacing the nuclei, and these are widely infiltrative. And their Gleason score is actually not recommended. They are also responder. Aberrant expression of P63 in prostate cancer. This is another variant. Here, a mixture of atrophic glands, poorly formed or solid, with glands having multilayered spindle and basaloid nuclei. Nuclei are present and prominent. In few cases, the neoplastic glands are more akin to usual type of atrophic adenocarcinoma and lined by columnar cells. And they usually, they express P63, CK18, CK8, and androgen receptors. And they are same as usual acinar adenocarcinoma. They are also responder. Lymphoepithelioma-like variant characterized by syncytial growth and dense lymphocyte infiltration in the background, but no EB virus association. They are PSA and MHR positive, and they are not recommended for assigning a Gleason score. They are non-responder to androgen therapy. Prostate carcinoma with stratified epithelium pin-like. This is another variant here. Glands lined by more than 2 layers of malignant cells may resemble flat or tufted high-grade pin like, and they lack basal cells. Here P63 are completely negative. Here also Gleason scoring not recommended, and they are also responder. Basal and adenoid cystic carcinoma. These are basaloid tumor cells, have scant cytoplasm, high nuclear cytoplasmic ratio, irregular or angulated nuclei with open chromatin. And they have actually two patterns. One is basal cell pattern, another is adenoid cystic pattern. And here also Gleason score is not recommended. They are not non-responder. Carcinoma with squamous differentiation. Glandular component are similar to the acinar adenocarcinoma. Squamous and glandular component intermingled. Here, the squamous cells are negative for PSA, also not recommended for Gleason scoring assignment. They are also non-responder. Urothelial carcinoma of prostate. Here, diagnostic criteria identical to those of bladder cancer. Here, PSA and other markers of prostatic epithelium are negative. Beta3 positive, CK7 positive, CK20 positive, and P63 positive. Also thrombomodulin positive. Gleason scoring is not recommended. They are non-responder. Ductal adenocarcinoma, large glandular and papillary architecture lined by tall columnar cell, open with pseudo-stratified growth, papillary cribriform, individual glands or solid, tall columnar cells in pseudo-stratified growth pattern, cytoplasm usually amphiphilic and nucleus obligated with variably prominent nucleolus. They are MHR positive, and ISU recommends 4+4, and if there is necrosis, then it is 5. They are also responder. Sarcomatoid carcinoma, carcinoma admixed with sarcomatoid spindle cell component, carcinoma admixed with sarcomatous component containing heterologous elements, and monophasic spindle cell tumor with evidence of epithelial differentiation. The carcinoma usually PSA positive. Spindle cells at least should be focally positive for at least one epithelial marker. Here, the assignment of Gleason score is not recommended. They are non-responder. Small cell carcinoma, histologically similar to small cell carcinoma of lung. They are small blue cell tumor with scanned cytoplasm, high ANC ratio, salt and pepper chromatin, nuclear molding, single cell necrosis or geographic necrosis, and smearing artifact. Half of the small cell have acinar adenocarcinoma component. They are synaptophysin positive, chromogranin positive, CD56 positive, as we know from the lung small cell carcinoma. Here also glycine scoring is not recommended. They are non-responder. And the last variant is pleomorphic giant cell carcinoma. Large Bezier tumor cells with prominent nucleoli, multiple coexistent histology component. The Bezier giant cells are positive for cytokeratin, and PSA may be negative or different degree of positivity. Here also glycine scoring not recommended, and they are non-responder. So this is the cytohyperplastic variant. This is the foamy gland variant. This is the colloid carcinoma, and this is the signet ring cell variant. This is the basaloid tumor. Actually, it is basal cell carcinoma. Here, solid nests of basal cells arranged in cords or trabecula, and peripheral palisading of the basaloid cells. And this is the adenoid cystic carcinoma, adenoid cystic variant of this group of tumor. Then this one is carcinoma with squamous differentiation. Here, the tumor cells grow in nest with cytoplasmic atypia, and also they show infiltrative pattern. And this one is urothelial carcinoma of the prostate. They are actually identical to urothelial carcinoma. They present extensive areas of necrosis. Here is the ductal carcinoma. These ductal carcinomas, they show a cribriform structure, and they are lined by tall columnar cells with pseudo-stratification, with pseudo-stratified growth. Their cytoplasm is amphiphilic, and nucleus oblongated with prominent nucleolus. Here, ductal adenocarcinoma with papillary pattern, with papillary architecture formation, and these two are actually sarcomatoid carcinoma. This is the small cell neuroendocrine carcinoma, and this one is pleomorphic giant cell carcinoma. Pleomorphic giant cell carcinoma, and they are pan-keratin positive. So they are actually diagnostic criteria. They must have a positive pan-keratin. Now we'll see very shortly radical prostatectomy specimen. The radical prostatectomy, we get these structures we all know, and this is the radical prostatectomy sample. And pathologist's role is to provide diagnostic and prognostic information to the clinician and patient. This is achieved by adequate tumor sampling, margin assessment, staging information, and remember, you have only one chance to adequately examine this specimen. So be careful from the very beginning. there is no pathological T1 stage in prostate cancer. It starts from T2, then T3. So T2 cancer is organ confined cancer. T3 cancer, when it extending beyond the prostate. So 3A and 3B, there are two subgroups. 3A, extraprostatic extension, focal, if it is less than 1 high power field. And T3B, seminal vesicle muscle wall invasion. When muscle wall of seminal vesicle is invaded, then it is T3. And T4 is invasion of external sphincter, rectum, bladder, levator muscle, or pelvic wall. So this is the staging. Now this is the schematic diagram of grossing of radical prostatectomy. This is the whole mount prostate. And you see, this is a tumor. It is T2 tumor, extra prostatic extension negative and margin negative. This one, it is T3. Here is extra prostatic extension, but margin negative. Here it is T3, extra prostatic extension positive and margin positive. Sometimes the surgeon actually cuts the capsule. Then we may find upstaging, and we should be careful not to stage on these sides. So we'll have to see whether it is really extraprostatic extension and margin is really positive or not. Now we'll show some examples of prostate cancer. Here a 66-year-old man with benign prostatic hyperplasia underwent a TURP and choose the correct diagnosis. So this is the TURP sample. Here the nest of tumor cells, and in the background there is hemorrhage, and here there are infarction, a little bit high power. These cells look like urothelial epithelium, and also in some places there are questionable squamous differentiation. The blood vessels are congested and hemorrhage in the background. This same thing, similar thing. Now the choices are infiltrating urothelial carcinoma, infiltrating squamous cell carcinoma with urothelial differentiation, and prostatic infarct with reactive urothelium. So these three are choices. Now we have to decide whether it is infiltrating urothelial carcinoma or infiltrating squamous cell carcinoma with urothelial differentiation, or prostatic infarct with reactive urothelium. So now let's see, this is actually prostatic infarct with reactive urothelium. Multiple prostatic chips have areas at low magnification with recent hemorrhage. And in some of the chips, there is infarcted tissue with ghost of tubules. Surrounding these infarcts are nests with a urothelial appearance. Cytologically, some of the urothelial appearing cells are moderately atypical with scattered mitotic figures identified. In other chips, no infected tissue is noted, but the same nests are seen amongst recent hemorrhage. So this is the prostatic infarct with a reactive epithelium. This is a 5.2 centimeter mass noted on imaging of the prostate and was resected by a simple prostatectomy. High power view. There is a proliferation of spindle cells, and here and there the glands are compressed. Here is a atrophic gland, here also, here also. These are atrophic glands, compressed glands, and the main bulk of the tumor is made of spindle cells, and these spindle cells are admixtured with some lymphocytes, and these spindle cells have a peculiar appearance, the so-called tissue culture appearance. Here you can see the compressed gland. This is more high power. So here our choices are leiomyosarcoma, inflammatory myofibroblastic tumor, sarcomatoid carcinoma or carcinosarcoma. So these three are actually differential diagnosis of this case. Now let's see the diagnosis: inflammatory myofibroblastic tumor. Now this is another case, 72 years old male with abnormal prostate, but normal PSA. This is the needle biopsy sample. Here you see the hyperchromatic cells. The size of the cells are small, no nucleoli. This is high power, no nucleoli, hyperchromatic, closely packed cells. So what is the diagnosis? So here the choices are adenocarcinoma of the prostate, Gleason 5+5, metastatic small cell carcinoma primary to the prostate, prostatic adenocarcinoma with neuroendocrine differentiation. So these are the choices, and we'll have to now decide what is it. Actually, it is small cell carcinoma primary to the prostate. Now, 40 to 50% of small cell carcinomas have a history of usual prostatic adenocarcinoma. The interval between the diagnosis of small cell carcinoma and prior usual prostatic cancer ranges from 1 to 300 months. Median is 25 months, that means 2 years. Historically, pure small cell carcinoma was seen at initial diagnosis in about 50 to 60% of the cases, with the remaining cases admixed with prostatic adenocarcinoma. And it is important after treatment. Now, a little about neuroendocrine differentiation in prostate. The normal prostate contains normal neuroendocrine cell. So there are some differences between normal neuroendocrine cell and tumor neuroendocrine cells. Normal neuroendocrine cells are androgen receptor negative. They are also androgen receptor negative. Non or low proliferative activity. Here also non or low proliferating activity. They are PSA negative. The tumor are also PSA negative. Here BCL2 negative. The normal neuroendocrine cells are BCL2 negative, but the tumor neuroendocrine cells are BCL2 positive. They are Amica negative, they are Amica positive. Here cytokeratin 5 is positive, here cytokeratin 18 is positive. Here they are non-aggressive, but here they are highly aggressive. So even the neuroendocrine normal cells, they have some functions. Now we'll see the functions of neuroendocrine cells. Here is for prostate cancer, there are two pathways. One is androgen dependent pathway, another is androgen independent pathway. Androgen dependent pathway, that means the testosterone, they bind with heat shock protein or androgen receptor. Then they activate the androgen response element, and finally prostatic cancer grows. But here the androgen independent pathway, here the androgen receptors are mutated. So there are some growth factors and other ligands. They can activate and they follow this pathway. But here is a bypass pathway. Here there is BCL2 activation. There are loss of P10 and P60, P13 loss. So they actually produce over expression of BCL2, and they then transform some neuropeptides from the neuroendocrine-like cells, and they actually, by passing the androgen receptor, they produces prostate cancer. So we get this type of cancer. And actually, there is another theory that usual acinar adenocarcinoma contains small amount of neuroendocrine carcinoma that is overlooked. If we can see the neuroendocrine marker on all the prostate acinar adenocarcinoma, we will see certain percentage of cases are actually containing neuroendocrine tumor focus. So when these patients are treated by androgen therapy, the acinar adenocarcinoma part goes away, but the neuroendocrine carcinoma, they remains, and that takes about 2 to 3 years for overgrowth. So with this time, with the treatment of neuroendocrine, with the treatment of androgen, we'll face seriously the problem of neuroendocrine carcinoma in near future. Now this is our next case, a 65-year-old man with an elevated serum PSA level, underwent 12 core biopsy. This is a glandular architecture. Here also extensive necrosis, immediate tumor necrosis. Here marked pleomorphism, extensive pleomorphism. There are atypical mitosis, individual cell necrosis. So it is somehow unusual with prostatic usual adenocarcinoma. Then this is the classical adenocarcinoma 4+3 adenocarcinoma. So this is some core contents like this and some core contents like these areas. So what is the diagnosis? So grade group 5 adenocarcinoma of prostate, or pleomorphic giant cell adenocarcinoma of the prostate, non-prostatic carcinoma, or high-grade prostatic ductal carcinoma. So these are 4 choices. So it is a poorly differentiated adenocarcinoma, and the tumor cells are pleomorphic, not uniform. So this tumor shows CDX2 positive. So CDX2 positivity. So what is the diagnosis? It is the colonic adenocarcinoma that has been metastasized or infiltrated into the prostate. That prostate also contains a 4+3 adenocarcinoma. So our next case is 65 years old TURP sample. Here, these are normal, and these fragments are tumor. These fragments are tumor fragments. These are normal. So normal, and this is a tumor fragment. Here also high power view of normal fragment. This is the high power view of tumor. This is the high power view of tumor. So these are actually basaloid cells, and let's see the choices. One is small cell carcinoma, urothelial carcinoma, basal cell carcinoma, basal cell hyperplasia. So these are a choice. And here the diagnosis is basal cell carcinoma. Nest of tumor cells arranged in an adenoid cystic pattern. Cells have small nuclei with inconspicuous nucleoli and scant cytoplasm. There is palisading towards the periphery of the nest, and the center show cells with eosinophilic cytoplasm. Next case, 59 years old male who underwent prostatectomy. So this is the scanning view of, this is the low power view. So the prostatic architecture is lost, and the prostatic architecture is replaced by infiltration of lymphocytes and other inflammatory cells, and also some spindle cell proliferation. And in the next, here is a very dilated duct containing polymorphs. Dilated ducts containing polymorphs. Here you see the lymphocytes are infiltrating, lymphocytes and histiocytes. High power view. So diagnostic choices are prostatic adenocarcinoma with granulomatous inflammation, infectious prostatitis, non-specific granulomatous prostatitis, post-biopsy granulomatous prostatitis. And here is the choices, here is the diagnosis of this non-specific granulomatous prostatitis. And what is the clue? The clue is the dilated ducts and acini filled with neutrophils, debris, foamy histiocytes, and desquamated epithelial cells. Ruptured ducts actually, they produce granulomatous inflammation and chronic inflammatory infiltrate. Our next a 67-year-old man was diagnosed with tumor on needle biopsy and underwent a radical prostatectomy. A Ki-67 was performed which showed less than 10% positivity. This is the tumor. Let's go to the high power. Here, the tumor cells are monomorphic. They don't show any pleomorphism without any necrosis. Here, the high power view, no nucleoli. So, the nucleoli are conspicuous or without nucleoli, they look like salt and pepper chromatin. So here the choices are Gleason score 5+5, 10 adenocarcinoma, small cell carcinoma, large cell neuroendocrine carcinoma, and carcinoid. So these are the choices. So it is not actually prostatic acinar adenocarcinoma. It is carcinoid tumor. The tumor consists of large islands of tumor with surrounding dense hyalinized stroma. Within the islands are ribbons of cells with round uniform nuclei with delicate salt and pepper chromatin and a moderate amount of eosinophilic cytoplasm. Scattered mitotic figures are noted. In the center of the nests are sheets of pycnotic discohesive tumor cells, which looks different from the surrounding more organoid appearance. And these cells are CK20, these cells are negative for prostate cancer and urothelial cancer, but they are positive for synaptophysin, and Ki-66 index is low. So the diagnosis is carcinoid tumor. Carcinoid tumor in prostate is very rare, but it happens. This is a tumor of 75-year-old man was noted to have a papillary lesion at the Verumon mountainum in the prostatic urethra, which was removed by transurethral resection. And this is the tumor. Here we have the glandular pattern, and at the same time we have this pseudo-stratified pattern. So this is the pseudo-stratified pattern. So this pseudo-stratified pattern and the cripiform pattern both are present. So the choices are prostatic ductal adenocarcinoma, intraductal carcinoma, prostatic urothelial polyp, prostatic urethral polyp, and high-grade papillary urethral. So these are choices, and here the tumor consists of both papillary fronts and cribiform structure. These cells lining the papillary fronts are pseudostratified columnar. The cribiform glands have variably the same pseudostratified columnar epithelium or more cuboidal epithelium. And there is not a lot of cytological atypia with relatively few mitotic figure. And this is the prostatic ductal adenocarcinoma. And prostatic ductal adenocarcinoma is Gleason grade 4. And if there is associated necrosis, then it is grade 5. This is another 53-year-old man presented with urinary obstructive symptoms, underwent a TURP. Here is the tumor and here is other areas. So there is some types of tumor, there is another types of tumor. Here is the tumor cells show squamous differentiation. But here, these are different from here. So this is squamous component. And here we see glandular carcinoma, glandular differentiation. So the choices are prostatic adenocarcinoma, urothelial carcinoma with glandular differentiation, prostatic adenosquamous carcinoma, and poorly differentiated squamous cell carcinoma. So these are choices. And here the diagnosis is prostatic adenosquamous carcinoma. The cribriform glands, nest and cords of cells with necrosis. At the same time, there are some squamous differentiation and keratin pearl formation. So this is adenosquamous carcinoma of prostate. Another case, 74 years old man, TURP. Here is the tumor. These are normal. So this is a normal gland. Here the tumor component. So these tumor cells look like urothelium. They look like urothelium. And they don't show infiltrating pattern. The tumor cells are not infiltrating into the surrounding stroma. So what are the choices? CIS, carcinoma in situ involving prostatic ducts and acini, infiltrating urothelial carcinoma involving the prostate, CIS with invasive urothelial carcinoma in the prostate, or Gleason score 5+5, 10 adenocarcinoma. So these are choices. So here the diagnosis is CIS involving prostatic ducts and acini. Solid nest composed of pleomorphic cells, where the nests fit in with the normal architecture of the prostatic glands in terms of size, shape, and distribution. There is lack of stromal reaction surrounding the nest. So it is CIS. This is an 80 years old man underwent a TURP for prostatic symptoms. The high power, more high power. So here the choices are basal cell carcinoma of prostate, basal cell hyperplasia of prostate, combined basal cell hyperplasia and basal cell carcinoma, metastatic adenoid cystic carcinoma of the salivary gland. So these are choices. And the diagnosis is actually basal cell carcinoma of the prostate. This is 80-year-old man underwent a simple prostatectomy for lower urinary tract symptoms. High power. So it looks like adenoid cystic carcinoma of salivary gland. So the choices are metastatic adenoid cystic carcinoma from salivary gland, adenoid cystic carcinoma of the prostate, adenoid basal cell hyperplasia of the prostate, clear cell cribriform hyperplasia. So these are actually choices. And the diagnosis is adenoid cystic carcinoma of the prostate. The lesion consists of numerous basaloid cribriform glands populated by relatively bland cells with scant cytoplasm. The lumina within the cribriform glands contain dense pink secretions. In addition, there are foci composed of small solid nests with similar cells and peripheral palisading. Focally, there is squamous differentiation with clear cytoplasm. This is a 71-year-old man underwent a TURP for urinary obstructive symptom. So these are normal only. This one is the tumor focus, high power view, and here is adenosis and basal cell hyperplasia, adenosis and basal cell carcinoma, adenocarcinoma and basal cell hyperplasia, adenocarcinoma and basal cell carcinoma. So these are choices. So here it is not malignant, it is actually adenosis and basal cell hyperplasia. The correct answer is the first one. A 70-year-old man underwent for a TURP for lower urinary tract symptoms. This is a hyper view, more hyper. And here the choices are adenocarcinoma of the prostate, Gleason score 3+5, 8, urothelial carcinoma, basal cell hyperplasia, basal cell carcinoma. So these are choices. Here the answer is basal cell hyperplasia. Our next case is a 65-year-old noted to have a nodule on digital rectal examination and underwent a prostate needle biopsy. Here, there is some sorts of granuloma, and GMS. Here the choices are non-specific granulomatous prostatitis, BCG-related granuloma, other infectious granuloma, sarcoidosis. Actually, this is histoplasmosis. This is a very interesting lesion. 70-year-old male underwent a TURP for lower urinary tract obstructive symptoms. There are small glands with secretions. The glands, small glands, and here the diagnosis is adenosis. And why it is adenosis? You see the basal cell marker. The basal cell marker is positive. So almost all of the glands has got positive basal cells surrounding them. And this is a 79 years old male, prostatic needle biopsy. This is Fontana Mason. This is GMS. These are, so it is cryptococcosis. This is another case, a 64-year-old male presented with a prostate and the needle biopsy. Here are something, these are so the choices are non-specific granulomatous prostatitis, malakoplakia, Gleason 5+5 adenocarcinoma of the prostate, and cryptococcosis. Here is the diagnosis is malakoplakia. Because those are actually Michaelis-Gutmann bodies. They have a targetoid appearance. This is an 81-year-old male with a prostatic nodule, needle biopsy. So this area, it shows proliferation of spindle cells without any glands and proliferation of blood vessels. So proliferation of thick-walled, medium-sized blood vessels. So here the choices are stromal tumor of uncertain malignant potential, low-grade stromal sarcoma, stromal nodular hyperplasia, solitary fibrous tumor. So these are choices, and the diagnosis here is stromal nodular hyperplasia. The 4 patterns of stromal tumor of uncertain malignant potential have been described. So one is hypercellular stroma with scattered, atypical but degenerative appearing cells admixed with benign prostatic glands. Another one is hypercellular stroma consists of blunt fusiform stromal cells with eosinophilic cytoplasm admixed with benign glands. Leaf-like hypocellular fibrous stroma covered by benign appearing prostatic epithelium, similar in morphology to a benign phylloid tumor of breast, and myxoid stroma containing bland stromal cells and often lacking admixed gland. So this is next case, 58 years old male. So it looks like something we know already. There is a lesion, similar lesion in breast. So these are glands and stromal overgrowth, stromal outgrowth, and it creates slit-like cystic spaces. The stromal cells with myxoid chains. So the choices here are benign prostatic hyperplasia, prostatic cyst adenoma, benign phylloid tumor, and detention cyst. So these are choices. These are actually differential diagnosis of this lesion, and the diagnosis is benign phyllodes tumor. This is a 70-year-old male patient with lytic bone lesion. Bone and the tumor cells. The tumor cells. So immunohistochemistry, PSA positive. So it is actually prostate cancer metastasized into bone. So metastatic adenocarcinoma of the prostate, although these are choices: metastatic sarcomatoid renal cell carcinoma, multiple myeloma, metastatic adenocarcinoma of lung. But here the PSA and other prostatic markers are positive in this case. This one is a 68 years old male with diagnosed with prostate cancer, underwent a radical prostatectomy. So this is the tumor. And this is the tumor. It creates papillary structure, and the papilla are lined by pseudostratified columnar epithelium. These cells show pseudostratification, papillary structure, pseudostratification. So there are choices: prostatic duct adenocarcinoma, Gleason 4+4, pin-like prostatic duct adenocarcinoma, and high-grade pin. So these three are choices, and the diagnosis is pin-like prostatic duct adenocarcinoma. So within the peripheral zone are dilated cystic and crowded glands with a more basophilic appearance than the adjacent benign prostatic glands. Some of these cystically dilated glands have papillary infoldings, while others are lined by flat epithelial lining and others by cystically flat lining. Cytologically, these cells are pseudostratified and columnar with prominent nucleoli. Cytoplasm is amphiphilic. Some of the dilated cystic glands appear to be outside the prostate within the periprostatic adipose tissue. So this is a relatively new entity, and this is a very interesting case. 61-year-old male with a history of clear cell carcinoma of kidney, diagnosed 3 years ago, presented with a prostatic mass. So a known case of clear cell carcinoma of kidney 3 years ago, presented with a prostatic mass, and transurethral resection was performed. So the tumor cells are large and very pleomorphic, atypical mitosis, almost Y-shaped. Highly pleomorphic tumor. So here the choices are urothelial carcinoma, prostate carcinoma, metastatic renal cell carcinoma, and melanoma. So these are choices. But finally, it came out as prostatic adenocarcinoma. The tumor consists of nest of cells with marked pleomorphism. The cells have abundant, highly eosinophilic cytoplasm with nuclei in areas with multinucleation, bizarre shapes, and mitotic figures, including atypical mitotic figures. Other areas of the tumors are not quite as pleomorphic, where cells are relatively more uniform with smaller nucleoli. No overt glandular differentiation is identified. So based on this morphology, initially it was thought that it is urothelial carcinoma, but on immunohistochemistry, the prostatic markers came positive and the urothelial markers are negative. So it is prostatic carcinoma. Now, another 70-year-old man presented with symptoms of BPH, TURP was done. Here, the basal cell markers are positive. So the choices are prostatic adenocarcinoma, Gleason grade 3+2, nephrogenic adenoma, prostatic sclerosing adenosis, prostatic stromal tumor of undetermined malignant potential. So here the diagnosis is prostatic sclerosing adenosis. A 79 years old male presented with hematuria and elevated PSA. He underwent a 12-core prostatic biopsy. This is the tumor and it looks like urothelial, urothelium, and the prostatic basal cell markers are positive. Thrombomodulin is also positive. So choices are adenocarcinoma, Gleason grade 4+5/9, basal cell hyperplasia with atypia, high-grade PIN, high-grade urothelial carcinoma with prostatic intraductal spread. So here the diagnosis is high-grade urothelial carcinoma with prostatic intraductal spread. And another case, 27 months old boy with a 8.2 centimeter prostatic mass involving the bladder wall. This is a spindle cell tumor with hyperchromatic nuclei, but not much pleomorphism. There are mitosis, increased number of mitosis. So the differential diagnoses are inflammatory myofibroblastic tumor, synovial sarcoma, embryonal rhabdomyosarcoma, and desmoplastic small round cell tumor. So at this location, embryonal rhabdomyosarcoma is the commonest, and also this tumor shows myogenin and MyoD1 positive. So it is embryonal rhabdomyosarcoma. This one is a 58 years old male, TURP. Here again, it shows some sorts of lesion we usually see in breast. Here is the spindle component or stromal component is more than the glandular component, and there are some atypia. So the differentials are malignant phylloid tumor, benign phylloid tumor, atypical fibroadenoma, and sarcomatoid carcinoma or carcinosarcoma. So considering the stromal cellularity and atypia, it is a malignant phylloid tumor. This is another case, elevated PSA level. This is, it shows mostly urothelial-like cells. The gland lumens are filled up with urothelial-like cells. These are urothelium-like cells. So here, benign prostatic hyperplasia with basal cell hyperplasia, urothelial carcinoma of urethral or bladder origin with prostatic intraductal spread, prostatic basal cell carcinoma, adenoid cystic variant, prostatic duct adenocarcinoma. These are choices. The correct answer is urothelial carcinoma of urethral or bladder origin with prostatic intraductal spread. This is another case. Pseudostratification. Pseudostratification. So the differential is pin-like duct, high-grade pin, metastatic adenocarcinoma of colon, classic prostatic ductal. So among these four, the diagnosis is pin-like ductal adenocarcinoma. "69-year-old male presented with elevated serum PSA level and under prostate needle biopsy. These are glands and dense infiltration of acute and chronic inflammatory cells. These are glands. Oh, so glands, and the gland lumen contains acute and chronic inflammatory cells. There are some polymorphs and lymphocytes, but look at the glands. These gland epithelium, with, they don't have basal cell. So the choices are benign prostate glands with marked inflammation, non-specific granulomatous prostatitis, adenocarcinoma of the prostate, non-specific granulomatous prostatitis, and adenocarcinoma of the prostate. So these four are choices. So benign prostatic gland with marked inflammation, non-specific granulomatous prostatitis, adenocarcinoma of the prostate, and non-specific granulomatous prostatitis and adenocarcinoma of the prostate. These are actually choices. So among these four, the diagnosis is the last one, non-specific granulomatous prostatitis and adenocarcinoma of the prostate. This is a 66-year-old man with prostate cancer diagnosed a year ago, was treated with brachytherapy. So majority are stromal component, only small amount of glandular component, small amount of glandular component. So adenocarcinoma of the choices are adenocarcinoma of prostate with CIS of the prostatic urethra, adenocarcinoma of prostate with reactive prostatic urethral urothelium, benign prostatic tissue with radiation, atypia and CIS, benign prostatic tissue with radiation, atypia and prostatic urethra with radiation, atypia. So among these four, the last one is the correct answer. Here is the radiation atypia involving the urethra as well as prostatic tissue. This one is a 26-year-old male with a prostatic and bladder mass. 26-year-old. Here the normal prostatic tissue, but here is the tumor. Here are also the tumors. This is the tumor. The tumor cells are to some extent monotonous. They have abundant cytoplasm. and they have an organoid pattern. So the choices are prostatic adenocarcinoma Gleason 3+3, 6, prostatic adenocarcinoma Gleason 4+4, 8, Phyloids tumor of the prostate, and paraganglioma. So these 4 are choices, and the diagnosis is paraganglioma. They were actually synaptophysin and chromogranin positive, and cytokeratin was negative. S100 was positive as a sustained tubular pattern. So it is paraganglioma. And the last case, 82-year-old male was noted to have enlarged left pelvic lymph node following needle biopsy, diagnosis of adenocarcinoma of the prostate. So this patient had adenocarcinoma of the prostate diagnosed by needle biopsy. Then they resected the left pelvic lymph node, and here is the pelvic lymph node. The high power view shows squamous pearl formation. Here also some area could be glandular, but there are obvious squamous differentiation, and the high molecular weight keratin is positive. So it is squamous. At the same time, in some areas, the PSA is positive. So in the lymph node, both PSA positive and squamous, high molecular weight keratin positive. So now the question is metastatic adenocarcinoma of the colon, radiation effect, and metastatic adenosquamous cell carcinoma of the prostate. So these are actually differentials here. And obviously it is metastatic adenosquamous carcinoma of the prostate. So before finishing, this is the whole lot of prostate pathology represented in one picture. So everything is here. We discussed for last 2 days. Everything is here. Everything is in this picture, this plan. Thank you very much. Thank you very much.
Thank you.
কি নাসিম নাই নাকি?
Thank you, sir, for your nice presentation.
নাসিম স্যার আনমিউট করেন। নাসিম স্যার আনমিউট করেন।
লিভ করব না।
মাইক্রোফোন ঠিক করেন, শোনা যাচ্ছে না।
নাসিম কি শুনতে পাচ্ছ? হ্যাঁ কবির, তুমি শুরু করো।
আমাদের বড় স্যার উনি একটা অন্য একটা ফাংশনে গেছিলেন, উনি তারপরও চেষ্টা করছেন, এই নেটওয়ার্ক পান নাই, তো উনি মানে আসলে আমাদের এখানে জয়েন করতে পারে নাই। এখন নাসিম মানে কনক্লুশন করার কথা আর কি, দেখি কি নেটওয়ার্ক আছে নাকি। তো আমাদের এখন তাইলে এই সেশনে আসলে আমাদের মেম্বার অফ দ্য এক্সপার্টস যারা আছেন ওনারা মানে আসলে এই কমেন্ট করবেন আর কি একটু। তো আমার মুখরানি স্যার বোধহয় কি উনি লিভ করছেন কিনা, ওনাকে তো দেখতেছি না। মুখরানি স্যার আছেন?
প্রশ্নোত্তর হবে না?
There are questions in the chat box.
স্যার চ্যাট বক্স থেকে কোশ্চেন দেখে দেখে উত্তর দিতে থাকেন, এর মধ্যে নাসিম ভাই আসুক।
উত্তর কি মোস্তফা দিবে নাকি?
হ্যাঁ, আমিও দিতে পারি।
হ্যালো
প্রথম মানে চ্যাট যেটা
হ্যালো হ্যালো হ্যালো।
হ্যাঁ শুনতে পাচ্ছি, কি ব্যাপার?
হ্যাঁ শোনা যাচ্ছে? ও আমি এখন ট্রাই করতেছিলাম, সরি ফর দ্য ডিসরাপশন।
কোশ্চেন সেশন
আমাকে
চ্যাট বক্স থেকে মানে আসলে কোশ্চেন পড়ে
চ্যাট বক্সের কোশ্চেন গুলোই আমি পড়ছি, দেখি একটু এক মিনিট। আচ্ছা, ফার্স্ট কোশ্চেন ছিল মাহবুবুল আলম, ব্রিগেডিয়ার জেনারেল মাহবুবুল আলম। তার কোশ্চেন হলো হোয়াট আর দ্য মরফোলজিক্যাল
What are the morphological criteria to differentiate high-grade prostatic
prostatic carcinoma from high-grade urothelial carcinoma? এটা কোশ্চেনটা আনসার কে করবে? প্রফেসর গোলাম মুস্তফা, প্লিজ আনসার টু দিস কোশ্চেন। What are the morphological criteria to differentiate high-grade prostatic carcinoma from high-grade urothelial carcinoma? Hello?
Hello. Actually, if it is really high grade, then it is morphologically it is very difficult to differentiate these two entities, and we have to depend on immunohistochemical markers.
Yes, immunohistochemical marker টা বলবে একটু।
For urothelial carcinoma, the CK7, CK20 and P63 and GETA3 are positive. And for prostate cancer, PSA is positive. So if we make a combination of PSA and GETA3, then you can differentiate these two. If PSA is positive, it is prostatic carcinoma. If GETA3 is positive, it is urothelial carcinoma.
Second question from Dr. Nafisa Sharmin Khan. The question is, stage 1B lesions have a mortality of about 20% if left untreated. If there is no pathologic stage 1, then how will we assume the lesion?
Actually, it is a stage 1, it is a clinical condition. Pathologically, T1 is non-existent. It starts from T2.
So there is no pathologic stage 1.
Yeah.
Patient should not.
Pathological, not stage, it is no T1.
No T1.
Yeah.
If there is any low grade
Organ confined prostate cancer, it starts from T2. So if only one lobe is involved, it is T1A. If both lobes are involved, it is T1B. Although in the new classification, in the recent update of staging, they are not encouraging to differentiate T1 and T2 and T2A and B. So they are calling all are T2. So we have T2, then T3A, T3B, and T4.
Next question, from Dr. Papia Rahman. How can we differentiate high-grade peen and intraductal carcinoma? Professor Mustafa.
Actually, high-grade peen and intraductal carcinoma, these two are totally different. Peen, high-grade peen, I think these 2 points, these 2 entities cannot be a differential because high-grade peen, it looks different, and the intraductal carcinoma is a high-grade tumor. High-grade peen is not a tumor even. So it cannot come into the differential of intraduct carcinoma. Intraduct carcinoma is a specialized type of tumor. It grows within the ducts, and it contains tumor papilla. They contains actually pseudo-stratified columnar type of epithelium. There are also areas where they show acinic type of differentiation or cribriform type of differentiation, but the main point is they are pseudo-stratified columnar type of epithelium, but those epithelium are malignant. So that is the intraduct carcinoma. And high-grade peen, it is not even a malignant entity.
Yes. Next question, Dr. Iftikhar has asked, can we differentiate between primary and metastatic small cell carcinoma of prostate by histomorphology and immunohistochemistry?
Morphology and immunohistochemistry all are same, both are same. But before making a diagnosis of primary prostatic small cell carcinoma, you will have to exclude others, especially the lung. So you will have to work out for lung. But both are same. All the immunohistochemical markers are also same, because the diagnostic criteria is you need only one marker positivity. So of all neuroendocrine marker, if one is positive, it is that neuroendocrine carcinoma. So you cannot differentiate. Even TTF1 is positive in prostatic small cell carcinoma, 50% cases. So you cannot differentiate small cell carcinoma of prostate from small cell carcinoma of lung. It is by the process of exclusion. You will have to exclude lung primary.
Professor Firdousi, want to add?
I'm agree with Professor Ghulam Mustafa sir, because lung small cell carcinoma also can also express TTF1, and actually to determine the primary site, it is the best way to explore the site of primary site through imaging, then through the IC workup. It is more logical, and it is written in the book also যে আপনি এত কত মার্কার দিবেন, এটা হলো আপনি রেডিওলজি দেখে সিটি এমআরআই that will detect the primary site.
Thank you, Professor Firdousi. Thank you very much. Now, question from Dr. Tasneem Ahmed. How could we differentiate basal cell hyperplasia and basal cell carcinoma? Professor Mustafa.
Basal cell carcinoma and basal cell hyperplasia, it actually differs in the extent of atypia. So if there is marked atypia, there is necrosis, it is basal cell carcinoma. And if there is no necrosis or very minimum or no mitosis and no atypia, then it is basal cell hyperplasia. Even any immunohistochemistry cannot help to differentiate these two.
What about P63 expression in
Both-
case of
both-
basal cell hyperplasia?
Both P63 will be positive.
Oh.
Because P63 is a marker of basal cell. So in hyperplasia, it will be positive. Even in carcinoma, it will be positive. So there is no way of differentiating hyperplasia from carcinoma.
Morphology is the gold standard.
By morphology, and if you see severe atypia, severe, if you see numerous mitosis, you see necrosis, it is basal cell carcinoma. In our case series, both basal cell hyperplasia and basal cell carcinoma are present. You can compare later on.
Okay, thank you.
Thank you. There are no questions, but there are several persons. Thanks, Professor Ghulam Mustafa, and for his nice presentation. Now, I invite Dr. Nurul Kabir to say something about today's presentation and finally wrap up. I think Professor Oshim Ranjan Borua is not here. Is he?
Sir, there is a network disturbance. Sir cannot enter the session.
আচ্ছা, any comments further? আর কেউ যদি কমেন্ট করতে চান, প্লিজ আনমিউট করে কমেন্ট করতে পারেন অথবা প্রশ্ন রাখতে পারেন। আমরা আরেকটু 5 মিনিট আমরা করব, এক্সটেন্ড করব।
আচ্ছা, আমি একটু বলতে চাচ্ছি যে এই যে ডায়াগনোসিস দেখানোর পরে স্লাইডগুলো আবার একটু দেখালে পরে ভালো হয়।
আচ্ছা,
এটা তো এখন আর কিছু করার নাই। এটা প্রথমে
লম্বা প্রসেস, অনেক সময় লাগবে।
প্রথমে
নেক্সট টাইম থেকে ডায়াগনোসিসটা বলার পরে আবার স্লাইডটা একটু দেখালে মনে হয় সবার জন্য সুবিধা হবে।
ওটা তো প্রথমে চান্সে যদি বলতেন তাহলে হয়তো তো করা যেত।
ডক্টর শাহাব, you are from Canada. Dr. Shahabuddin,
Yes.
from Canada, you are
Yes.
asking questions. Thank you, but the name is Saim. Nobody will recognize you.
This is my son's name. I'm sorry for that. আমি মুস্তাফাকে অনেক ধন্যবাদ প্রেজেন্ট।
Thank you for your question. আসলে এটা আমিও ফিল করেছি যে যখন ডায়াগনোসিসটা বলা হচ্ছিল তখন আবার দেখতে ইচ্ছা করছিল যে ওই স্লাইডটা, তো এটা হয়তো
আসলে এটা আমি প্ল্যান করেছিলাম যে এটা ইন্টারঅ্যাক্টিভ করার জন্য।
হ্যাঁ, রাইট,
ইন্টারঅ্যাক্টিভ করার জন্য, মানে এটা পোল করার এর আগের দিন যেটা করেছিলাম,
আচ্ছা,
তো আমার প্ল্যান ছিল ওইটা করা, তো কিন্তু সেটা করতে পারি নাই টেকনিক্যাল কারণে। আজকে ওই যে পোল এটা অ্যাক্টিভেট করতে পারিনি।
আচ্ছা, ওটা কি মাঙ্কি
ওইটা হলে
সার্ভে মাঙ্কি?
আমার প্রথম থেকে প্ল্যান ছিল অ্যাক্টিভেট করা, অর্থাৎ সবাইকে নিয়ে যাওয়া, হ্যাঁ, প্রত্যেকে একটা সুযোগ দেওয়া, তারা কি মনে করছে, তারপরে ডায়াগনোসিসটা ডিসক্লোজ করা। তো কিন্তু ওই যে ওইটার জন্য একটা ইয়ে লাগে, তো ওইটা আজকে আমি অ্যাক্টিভেট করতে পারি নাই।
আচ্ছা, আর
যার ফলে একেবারে লাস্ট আওয়ার এই সন্ধ্যার আগে সেই আবার এই জিনিসটা চেঞ্জ করতে হচ্ছে আর কি।
আগের পোলটার রেজাল্ট দেওয়ার কথা ছিল, ইজ ইট পসিবল আজকে?
না, আজকে এখন পসিবল না। ওই আমার ওই পোলের ওই অ্যাকাউন্টটাই ঢুকতে পারিনি আর কি, ঢুকতে পারছি না বলেই আজকেও করতে পারি নাই।
এমনি রেকর্ডে পাওয়া যাবে তো, এই যে বললো যে সমিত্র মানে করে দিলে হয়তো পরে মানে কেউ রিভিউ করতে চাইলে পাবে আর কি।
না, এটা গত দিনের যে লেকচারটা সেটা রেকর্ড করে সৌমিত্র আমাকে পাঠিয়েছে, ওইটা ইউটিউবে আছে। আমি লিংকটা সাদেকুল তালুকদারকে পাঠিয়ে দেবো। কালকেরটাও আজকেরটাও আমি সৌমিত্রকে বলবো যে আমাকে পাঠিয়ে দিতে, আমি আবার এটা আপলোড করে দেব, দিয়ে এই লিংক হলো ওই সাদেকুলকে দিয়ে দিলে
জি
সাদেকুল হইলো ইয়েতে
স্যার ধন্যবাদ আপনাকে। আমাদের যে ওয়েবসাইট আছে bapath.org, এখানে আমাদের মিটিং নামে একটা বাটন আছে। এই মিটিং এর আন্ডারে আমরা এই সমস্ত এই লেকচার গুলার রেকর্ড আমরা লিংক দিব আর কি। আপনারা অলরেডি আমি গত মিটিং এর একটা লিংক দিয়েছি, ওখান থেকে সবাই দেখতে পারছে। যারা অ্যাটেন্ড করতে পারে নাই তারাও দেখতে পারছে। লিংকটা ওখানে যেহেতু পার্মানেন্ট থাকে, যে কোনো টাইমে বসে বসে দেখতে পারে। তাছাড়াও আমি ইমেইলে শেয়ার করব। তারপরে আমাদের কাছে যে 198টা মোবাইল নাম্বার আছে সেখানেও শেয়ার করব। আপনারা এই আমাদের ওয়েবসাইটটা শেয়ার করবেন সবাই ইনশাআল্লাহ। থ্যাংক ইউ।
থ্যাংক ইউ। তাহলে লিংকটা যদি ওয়েবসাইটে শেয়ার করেন মুস্তফা, দেন আমরা আমাদের সবারই সুযোগ থাকবে যে এটাকে ডাউনলোড করে নিয়ে আমরা দেখা। তো ঠিক আছে, আজকের সময় অবশ্য আমরা অনেকটুকুই বেশি নিয়ে ফেলেছি, যদি স্টার্টও করেছিলাম 10 মিনিট পর। এনিওয়ে আজকের সেশনটা র্যাপ আপ করার জন্য আমি ডক্টর নুরুল কবিরকে অনুরোধ জানাচ্ছি।
জি জি, এটা সৌমিত্র করবে। আচ্ছা, এখন এক্সপার্টদের মানে মতামতে আমাদের ফেরদৌসী আপু আছে এবং সাইকা আছে আর কি, তো ওনাদের একটু আরো
সাইকা আছে, ডক্টর সাইকা একটু
স্যার বোধহয় মানে লিভ করছেন, উনি মধ্যে নাই মনে হয় এখন।
মোকাররম স্যার তো ছিলেন, নেই এখন।
প্রথমে ছিলেন, হ্যাঁ। তো স্যারকে একটু ইয়ে করেন, রিমাইন্ডার দেন, না হলে মানে ওই যে
কাকে
আমাদের ফেরদৌসী আপু কিছু বলবে আবার হয়তো।
আচ্ছা আচ্ছা, আমি কি কিছু বলবো? আচ্ছা ঠিক আছে, অবশ্যই। Thanks to BAP, especially Scientific Secretary Professor Mohammad Nasimul Islam sir for inviting me, and special thanks to Professor Ghulam Mustafa sir for detailing prostatic cancer, and I think everyone we have gathered knowledge from his lecture. And from his lecture, actually, it has come to my mind that it is the right time to develop a subspecialty in pathology sector, because you have seen that in prostatic adenocarcinoma there are very various type of variant, and একজন প্যাথোলজিস্টের পক্ষে আসলে এত ভ্যারিয়েন্ট মনে রাখা এবং এত সঠিকভাবে রোগ নির্ণয় করা ইটস ডিফিকাল্ট। আমি আবারও থ্যাঙ্কস জানাচ্ছি বিএপি কে এবং প্রফেসর গোলাম মুস্তফা স্যারকে ওনার নাইস প্রেজেন্টেশনের জন্য। দ্যাটস অল ফ্রম মি, থ্যাংক ইউ।
ডক্টর সাইকা, you can give comment. ডক্টর সাইকা আছেন? I think she is not here.
হ্যাঁ, সাইকা জয়েন করছিল। সাইকা লিংক পাচ্ছে না।
আচ্ছা, তো আমাদের প্যানেল লিস্টের আর কেউ তো আজকে নেই।
হ্যাঁ, জয়নুল ভাই তো
থাকবেন না বলেছিলেন, ওকে জানিয়েছেন থাকবেন না।
কামাল স্যার মানে থাকবেন না বলছেন। কামরুল স্যার তো অসুস্থ, উনি করোনা আক্রান্ত।
তাই
জি, সবাই ওনার জন্য দোয়া করবেন অবশ্যই।
আচ্ছা, আমি একটা ঘোষণা এর সঙ্গে দিয়ে দিতে চাচ্ছি। আমাদের নেক্সট ওয়েবিনার যেটা হবে সেটা on the 8th January. That is scheduled for 8th January. আমাদের ব্রিগেডিয়ার জেনারেল মাহবুব সেটা প্রেজেন্ট করবেন এবং তার টপিকসটা হলো অন DLBCL এর উপর, লিম্ফোমার উপর ওনার অনেকগুলো কাজ আছে, সেই ব্যাপারে উনি প্রেজেন্ট করবেন। আই থিঙ্ক দ্যাট উইল বি কোয়াইট ইন্টারেস্টিং। প্লিজ জয়েন দ্যাট সেশন। আমরা সেশনের আগে আপনাদের কাছে লিংক পাঠিয়ে দেব। It is 8th of January. ডক্টর ব্রিগেডিয়ার জেনারেল মাহবুব, আপনি তো ছিলেন, আপনি আছেন?
হ্যাঁ, আমি পুরো সময় শুনেছি সবকিছু। থ্যাংক ইউ ভেরি মাচ। আমরা আপনি যেভাবে বলবেন আমি আরো ডিটেলস জেনে নেব কিভাবে ই করা যায় এবং টাইমলি এটা শেষ করার জন্য আমি ইয়ে করবো আর কি। পূর্ববর্তী বেশি রাখবো। আচ্ছা,
আমরা এই 8টার সময় হয়তো শুরু করবো আর কি, এই
আমরা শার্টলি
8 তারিখে, হ্যাঁ শুক্রবার রাত্রে। জি
থ্যাংক ইউ কবির ভাই।
ডক্টর কবির।
জি, আমি এবার আমার অংশটা আমি করি। I am Nurul Kabir, thanking to all on behalf of BAP. Here, Professor Mohammad Ghulam Mustafa delivered the second part of the lecture on prostate cancer. I am thanking him for his much informative message. I think he worked hard for this. We're also giving thanks to the member of the panel of experts for their valuable opinions, especially thanks to the Dr. Ferdousi, chairman of the Department of the Pathology, for her expert opinion. I am giving thanks to Dr. Soumitra Chakraborty for his technical support. He is our regular partner. Now he is also the member of BAP recently. We are grateful to all the participants who have enriched the session, and again giving thanks to everybody.
Thank you.
আর কেউ যদি না বলে, আমার মনে হয় আমাদের এখানে শেষ করা যেতে পারে, কনক্লুশন করে দেন। হ্যাঁ,
ক্লোজ করে দিব
না, কনক্লুশন হয়ে গেছে আমার মনে হয় আজকের জন্য। সবাইকে ধন্যবাদ।
আমি ক্লোজ করে দিচ্ছি স্যার, তারপরে রেকর্ডিংটা ডাউন কম্পাইল করে আমি পাঠিয়ে দিব স্যার।
জি ঠিক আছে,
থ্যাংক ইউ ভেরি মাচ ডক্টর সৌমিত্র। থ্যাঙ্কস।
মোস্তফা থেকে ভবিষ্যতে আরো কিছু সাপোর্ট চাবো। আমাদের মানে উনি একজন ভ্যালুয়েবল পারসন আমাদের জন্য, এবং আমাদের প্রাণ বলতে গেলে। আশা করি ভবিষ্যতে আমাদের সাহায্য করবেন।
সেই সঙ্গে আরো কেউ যদি প্রেজেন্ট করতে চান, আপনি করতে পারেন। আমাদের সব মেম্বারদের প্রতি আমাদের এটা অনুরোধ থাকবে, প্রেজেন্ট করতে চাইলে সেটা বলবেন আমাদের।
বাংলাদেশের যে কোনো প্রান্ত থেকেই মানে আসলে করতে পারবে, এটা ইজি প্রসেস।